Okay, our next session is the Neurology and Clinical Management of CACNA1A-related abnormal eye movement, dystonia, and imbalance. We're really thrilled and happy that three rockstar neurologists could join us today, Dr. Joanna Jen, Dr. Asif Sheikh, and Dr. Scott Grossman. We are going to start with Scott, Dr. Grossman, and we're really excited about this panel because one of the things they asked us to do in preparation for this panel is collect videos from all of you and all of our community so that they could speak directly to the issues that we are seeing in our kids and our patients. So they're going to be playing a series of videos through their talks, and they've also encouraged you, if you are interested during the Q&A session, if you want to bring your child in, or if you have CACNA1A and you want to come up on stage and be an example, that they're willing to sort of spend some time in the Q&A to examine or point out different features that you're experiencing. So thank you, and thank you, Dr. Grossman, for being here.
Great, thanks so much. If we could have the slides up. So like Sunitha mentioned, my name is Scott Grossman. I am a neurologist and a neuro-ophthalmologist at NYU. And so I'm a kind of doctor that sees patients who present to clinic with challenges in the way the brain and eyes work together to help people see their visual world and experience their world. And today I'm really proud to be part of this panel with Dr. Sheikh and Dr. Jen on eye movements, dystonia, and imbalance. And I'm going to go first to talk about the eye movement aspect of things. How do I advance the slides here? Great. And here's an outline of what I'm going to talk about. I also want to take a moment at the top, like Sunitha mentioned, to thank everyone in the CACNA1A community who contributed videos of their loved ones to help us demonstrate some really important examples of changes in the way the eyes move that can occur in CACNA1A. I'm going to talk at the beginning just a little bit about eye movements and their background and the nature of them and why they're important, and then touch on a number of different features of CACNA1A that may be relevant in this realm, including nystagmus, which is an abnormal dancing movement of the eyes, something called paroxysmal tonic upgaze, and then some other changes that we see. So by way of background and introduction, the really fundamental thing to think about when we think about eye movements is this concept of foveation. All of us, me, you, everyone who has CACNA1A, has a retina in the back of their eye with the portion of the retina that is the most important for visual acuity for experiencing our world. And the point of eye movements is to move that fovea onto our object of regard. And we have two main classes of eye movements that help us to move them. One is saccades, which are fast eye movements, some of the fastest movements that are actually propagated by the human body. And they bring the eye rapidly onto target of something that we're looking for. And also smooth pursuit, where we slowly move our eyes to follow a target in space. And this is also important because this picture on the bottom right, which is from one of our sort of the forefathers of eye movement, Dr. John Lee, shows that the area in the center of this picture, which is the area that we use our fovea to see, is a much better acuity, a higher ability to see than the area around that fovea. And so we're always trying to use that central area to experience our visual world. And this is really the point of the eye movements when we have a challenge with keeping our eyes still, or a challenge with moving our eyes rapidly or slowly to follow a target, then we're going to be seeing the world with an area that is not our best visual acuity, and that's really a challenge for folks, including those with CACNA1A. Nystagmus itself is an important thing to talk about, and like we said, it's a spontaneous movement, repetitive, to and fro, that can have a couple different characteristics. It can either be jerk nystagmus or can be pendular nystagmus. And on the right part of this slide, you see a couple different waveforms that help us demonstrate how the eyes move when we have nystagmus. With the slow phase, having the eyes move slow to one side, and the fast phase, the quick phase, where they jerk back to their original position. And we name nystagmus for that fast phase, that fast jerk. So we may talk today about things like downbeat nystagmus or right beat nystagmus, but actually the abnormal part is the drift, the slow drift back to primary. And on the right part, you'll also see at the bottom that there's an area in panel D, which is a pendular nystagmus, in which individuals can have the eyes that move continuously in basically a symmetric manner, predominantly horizontally. And there's no fast phase or slow phase like there are in the jerk nystagmus examples we see at the top. So we're going to try to play a number of videos today, and at this point I wanted to ask the AV team to play the first video. And this is an example of a pendular nystagmus, and we can see this patient's eyes are moving constantly. There's not a fast jerky phase like a dance back and forth, a slow constant movement, and this is an example of the way this patient would experience the visual world, because that fovea in the back of our eye, the retina, is constantly moving with respect to the environment. And as you can imagine, this is a challenge to see things like what we want to eat, to see our family, to see where we want to go. This kind of pendular nystagmus is actually not a nystagmus that's very frequent with CACNA1A, but it is just to give everyone an idea of what we experience when we have nystagmus. But to touch briefly on some examples of nystagmus that we can see with CACNA1A, specifically downbeat nystagmus. And this is a kind of nystagmus in which the eyes drift upwards and then beat down rapidly, jerk down rapidly. And remember, the part that's abnormal is actually that upward drift and our inability to keep our eyes even with respect to the visual world. So I wanted to play our first video of a contribution from a CACNA1A family. And we can see the eyes here, they're drifting up and beating down. Drifting up and beating down. And this is going to play a little bit on a loop here. And this kind of downbeat nystagmus we think of can occur in the setting of challenges to a couple different places in the nervous system, including where the brain meets the spinal cord, and also in areas of the cerebellum in the back of the brain. I'll also note, we can move forward here, that it's thought to be related to our brain's ability to keep our eyes still in the visual world. We often will also see people who have downbeat nystagmus in clinic from other causes, including a lot of different things in older individuals or younger individuals who come in. This phenomenon called side pocket phenomenon, in which people look to the sides with their downbeat nystagmus, and the amplitude, meaning the size of the nystagmus, will increase and also have a little bit of a direction that's down and to the sides. And this is an important thing if you're presenting initially as a new patient to a neuro-ophthalmologist or a neurologist in clinic, to make sure that we're examining and recognizing, because this can have important implications for diagnosis. And for us in neuro-ophthalmology, that's really one of our major roles, is interfacing with referring physicians to try to identify certain nystagmus patterns that can help lead to diagnosis ultimately, and differentiate causes of the eyes not moving or not staying still as they should. Another kind of nystagmus that we can see in CACNA1A, and we have a number of different examples of this that we're going to look at in a second, is called rebound nystagmus, which is a horizontal nystagmus in which individuals, when we're examining them in the room, will be asked to look to the side for 10 to 20 seconds and may have a little bit of a nystagmus that beats fast phase to the side and drifts towards the center. But then when they come back to look at us straight ahead, the direction of the nystagmus will reverse. So the fast phase will be to the left, and they'll drift back to the right. And this is an example from a colleague, Dr. Dan Gold, who has a great teaching set online that shows in rebound nystagmus example in an older individual who does not have CACNA1A. But I wanted to show this one to have us see an example of what rebound could look like. So if we can play this video, please. We're not able to play that video embedded in the slide. Oh, okay. So essentially that just shows what I described, in which the patient will drift to the side, come back in and have reversal of the nystagmus. So if we can forward here and show a couple examples from CACNA1A families. And what we look here, it's a lot of these eye movement changes are pretty subtle, right? But if we look at her eyes, we see that they're beating to the side and drifting back to the center. And if during the context of this exam over video, we were going to ask her to look back to camera right away, we may see a reversal in the direction of the nystagmus, a so-called rebound nystagmus. If we can move forward again. Here we see left beat and back to center, very subtle right beat there. Right beat when she looks to the right, and then up beat when she looks up. And this is a direction-changing nystagmus, which in some ways is what a rebound nystagmus is. Beating to the right, and beating to the, good. So beating towards the eccentric aspect of gaze. And move forward, please. Similarly here, this individual's lying on their side, but they're looking up. So it's actually in a horizontal gaze and beating to the, I guess this would be to the left if they're looking up and to the left in this rendering of the video. And so these are all people that if we were examining them in the office and we saw this kind of eccentric nystagmus, we would ask them to look back towards us in center and see, is there a reversal of the direction of the nystagmus that would be consistent with rebound? To move on now and talk a little bit about our next topic, which is paroxysmal tonic upgaze, an unusual circumstance that can be seen in children who come into pediatric neuro-ophthalmology clinic or pediatric ophthalmology or neurology clinic, in which the individuals can develop episodes where both eyes conjugately, meaning together, are forced up. And it can combine at the same time, because if our eyes are forced up and we want to experience our visual world in front of us, we may have to assume a chin down position to be able to look straight ahead of us, which is in combination with neck flexion and at times eyes beating down when looking down. These episodes can be variable in their duration, and I know a lot of folks in the audience look forward to talking with everyone later about these, lasting for minutes, hours, or days, and oftentimes can be relieved by sleep or by naps. So I wanted to show some examples on a video of what paroxysmal tonic upgaze would look like clinically. And the audio is not here on this video, but
5 minutes ago from almost a 2-hour nap. Before her nap, she did not have upgaze, and now she does have an upgaze going. Louise, where's the little person? Can you show me your favorite
we see
one?
here an example of that chin down
Today she is
position
sick.
to try to look
Right
at the
now,
family member who's
she's running
speaking
a
on camera.
low-grade fever. So I'll be curious to see if this goes away, but usually she has an upgaze until she naps. Today it seems to be the opposite. I know, baby. All right.
We can move forward here. And at this point, the child's interacting and working with the book, right, to point out different balls on the book. And in order to visualize the book and count the balls in the book, is assuming that chin down position with the paroxysmal
Let's count
tonic
some more
upgaze
balls
force.
for me. Ready? 1, 2, 3, 4, 5, 6.
Great. And one more.
Yeah, ponytail out too. All right, this is shortly after our visit with you today. Let me see if I can get her look down. Louise, look down at your bow. The upgaze kind of started in the car. You can kind of see it there now. Follow it up. Follow it back down with your eyes. Look, look, look. So we're tucking that
And we're
chin and
tracking
following
down
it with our
here.
whole head. Okay. Now, Louise, I need you to lay down so we can change your diaper. Lay down. Whoa. Slide down.
Seems less
Now, if you
evident
look at her
in
when
the
she's laying
supine
down.
laying down position.
You don't have the, I don't think we have a similar issue. So let's look down. Follow the bow. It's gone.
Great. And if we can move forward.
Look up at the bow. Now look down. Look down here at the bow.
So I did a pretty thorough review of some of the literature about paroxysmal tonic upgaze before today and looked through a number of different papers that have been published in the past couple of years, including one that was written by an Israeli group recently that attempted to characterize the differences between individuals who have PTU that's associated with CACNA1A and individuals who have so-called cryptogenic paroxysmal tonic upgaze, as in paroxysmal tonic upgaze that's not associated with the CACNA1A change. And they noticed that in this cohort, the duration of attacks ranged from 3 seconds to 2 hours, happened up to 10 times per day, and also had concurrent coordination difficulties, which we'll touch on and later on this session during some of the attacks. And I wanted to show one more video of another person with very brief episodes of the PTU, and we see the eyes moving up here. And maybe a little bit of changes in coordination there we can see with clapping during the PTU. Great. If we can move forward. This is a very busy slide that highlights the differences between CACNA1A associated PTU and this so-called cryptogenic PTU. Just to point out that those with CACNA1A have a tendency towards brief seconds-long episodes that start during the first months of life relative to the cryptogenic group. And at this point in the literature, the substrate, meaning the anatomy that underlies PTU, still remains unclear, but it's thought that it could suggest the dysfunction in the cerebellum because of the presence of Purkinje cells in that region. So finally, to touch on some other changes in eye movements before I wrap up. The kind of eye movement we talked about at the beginning, those really fast eye movements that bring our target into visual attention, the saccades, have also been found to be slow in individuals with CACNA1A, that's depicted in the bottom left panel on this slide here, and also specifically saccades that are in the eye movement in which the eye moves towards the nose when we're looking in either direction, which is called an adducting saccade, can be slow compared to eye movements when the eye moves out towards the side. And that's a special kind of change in eye movements that can speak to a difficulty with the way the eyes move together, a disyoking of the way the eyes move together, which is called an INO, internuclear ophthalmoplegia. And that means when we look to the side, we may notice that our eye that moves out moves faster than our eye that moves in. And we may also have limitations in range, meaning the degree to which our eye can move in all the way compared to our eye that moves out all the way. And I wanted to show a couple examples of some INOs that would be from other causes, things like stroke in older individuals. And I guess this video is not going to be able to be played, but I'll just point out that when we look to the side, this person will have their eye move all the way out, but their other eye will not move in at all. And that can be either a subtle finding or a very evident finding. And I wasn't able to find something like that on the different videos that individuals were submitting today for our review. So thanks so much to the CACNA1A Foundation and to Lisa and Sunitha for having me. And to all the families, it's really a pleasure and an honor to be here with you and learn more about this condition. Also to my mentors at NYU, Drs. Rucker, Balser, Galetta, and Cho. Thank you.
Hi, I have a question.
I'm just going to connect my computer because it will be easier with the videos. If this does not work out, then we have plan B. And it still shows aces. You don't see me? There we go. I can see me here. Thank you, everyone. Thanks, CACNA1A Foundation. It's very amazing, impressive story. The way the whole foundation came up, amazing. I've been telling everyone like how this thing evolved, and some of my female colleagues say that only moms can make that happen. So kudos to you all. So with that, we will talk a bit about dystonia and ataxias, and I'll try to link some of the eye movements that Dr. Grossman talked about, some of balance that Dr. Jan will talk about, and how eye movements, balance, dystonia, ataxia, everything mingles together, because the brain is not just different pieces, it's a bunch of different pieces connected together. So everything goes in synchrony, everything goes as a network. And all these problems that we see, it's a problem of a network. So we will talk a bit about something which is not so uncommon in CACNA1A, which is dystonia and ataxia. And the contemporary way of thinking of dystonias or ataxias, it all comes down to learning. Learning new plan for movement, learning new movement, learning how to correct for problems which happens with movements. And if you learn in either bad way or you don't learn at all. If you learn in bad way, it becomes dystonia. If you don't learn at all, it becomes ataxia. So this is what we will primarily talk about. And of course, I will again show some of the videos which are none other than yours. And if you have any comments, questions, I'm happy to speak with you. So what is learning? So this is a little cartoon of a brain. And let's say you want to learn piano. Okay? So when you start learning piano, certain part of the brains get active, and what we call learning. And then new synapses are made in the brain, and new connections are made in the brain, and you become pianist. Now let's say something happens and a key broke in the keyboard, and now you have a new key. So now you are learning how to get adapted, what we call, to that new key, right? So your brain has to now change, and it has to change the circuit a little bit differently, and it makes a new circuit, and it's called adapted pianist, or you adapt it to new keyboard, right? So this adaptation is a very important process, and adaptation happens in our day-to-day life, like you change your cell phone, or you change your computer keyboard, or things change because of unexpected circumstances. Everything leads to adaptation. And brain needs to get adapted day to day, and knowingly or unknowingly, you keep adapting. Now, how does brain cope with all these changes? So in general, it happens in two basic steps. One, you observe, or your brain observe, the difference between something which is done and something which is desired. So if I want to reach to this angle, this is accurately done, right? But if I don't reach there, then it is not done what was desired, right? So you find the difference between done and the desired. And then if there is a difference between done and the desire, then you account for that difference, what we call error, and you put that observation in the future task. And that's the key about learning. And motor system is a very accessible way to study this phenomenon, and a lot of problems our brain runs into, or our body runs into, with various disorders of brain that often is related to motor learning. So ataxia, that you all know very well, is one of the problems which is associated with motor learning. So this is, I tried to make a complex circuit little easy, but this is the best I could do. So there is something called olive. Just looks like an olive. It's in the brain, and that olive in the brain is connected to the workshop in the brain, which is called cerebellum. So what happens is, this is your hand, for example, and this is a cherry. Now your hand is trying to reach this cherry, and that you're reaching this cherry pretty precisely, right? So, which is good. Now something happens, let's say. You have new glasses, or your hand muscle has a little problem, something. What happens is, now your hand is not reaching to that cherry accurately, what we call ataxia, right? So that inaccurate movement leads to some sort of error, right? That error then goes to this inferior olive. This olive then sends a little signal to your cerebellum that, hey, there was an error. So what cerebellum does, it has cells which kind of pause each time when that error happens. That pause will then lead to learning, and that learning will correct the output that goes to the hand. So this is how our brain accounts for whatever was the difference between desired and done, and as a result, your future movement is corrected. So this happens day to day, every day, in anybody's life. You buy a new iPhone, or you buy a new piano, or whatnot. Now, let's say, unfortunately, there is something wrong with the cerebellum, right? So if there's something wrong with the cerebellum, that the error is not implemented in correct way, and when that happens, there are these inaccurate movements which are not corrected in a right way, which then leads to ataxia, all kind of postural problems, and many other things. So basically, ataxia and instability, my computer froze for a little bit. So ataxia and instability is one of the issues which could be related to cerebellum. I'm not going to talk a great deal about ataxia and instability because Dr. Jan will talk about that, but I will show you some basic videos as a reference of what is ataxia and how to separate them from the other conditions. So this is one of video of a cute little girl. As you can see, as she's trying to walk, walking is not just right, and there is bit instability, there is bit what we call ataxia of gait, right? And that ataxia, this is one of the forms of gait ataxia. Now, this is another condition which is not quite ataxia by definition, but what we call titubation. So if you look at this kid's head, it has a little bit of like fast nodding head movements. You can see it a bit from the back, like intermittently head nods. And that nodding head movement is more or less of what we call titubation, which is in a way of systems, in a way of network, in a way of scientific view of thinking, it is a cousin of ataxia. It all comes down to the error and system kind of resonates, and that leads to titubation. And this is, again, you saw this video for paroxysmal tonic upgaze, but in addition to that, he also has a bit of titubation, which is quite like very obviously you can see it here. And also like this clapping movements are not like the most smooth. They have some, I would say there is some dystonic component to it, but it is also mixed with some ataxia. So it's pretty heterogeneous form of movement disorder. We are seeing some ataxia, we are seeing paroxysmal tonic upgaze, we are seeing titubation, and I am also seeing some hand dystonia here. So it is, and also if you look at the leg here, the leg also has, oh, my arrow is not here, oh, here. So if you look at the leg here, when it tries to clap, leg kind of goes in abnormal contraction position, which is also kind of dystonia, which is provoked by other movement, what we call motor overflow. So one thing which Dr. Grossman talked a lot about was paroxysmal tonic upgaze, right? So when I was looking at this video, it was quite interesting, and I told Dr. Jan that we should talk more about this at lunch, maybe some new ideas. But the way brain deals with the eyes and the way brain deals with head, there are common cells. So if I turn, if you call me, if I look this way, I move my eye, then I move my head, then I move my eye. So eyes and head, they all go in synchrony, and they have a specific sequence. And the way that happens is the cells in the brain, they fire in such synchrony. So there are eye-sensitive neurons, there are head-sensitive neurons, and there are eye-head-sensitive neurons. So these all cells are in same area. So if something happens wrong with the eye-sensitive neurons, it is very possible that there may be some spillover to the head also. So if there is paroxysmal tonic upgaze with the eye, then this thing can possibly happen too. So in this video, what I'm seeing is that when this girl tries to look up, there is not just paroxysmal tonic upgaze, but there is also like head keeps going up on paroxysms. Now, I don't know how much of this is voluntary versus it is paroxysmal involuntary movement, but this is something we need to look at more. In addition to that, you can also see that fingers are very much contracted like this, and it changes, which is a form of dystonia. As you can see, there are some involuntary jaw movements, which can be some dystonic movements here, and some stereotypic movements as well. But again, this is a form of heterogeneous form of movement disorder that we are seeing in this kid. So dystonia. So what is dystonia? As we saw from all these different examples, they are abnormal twisting or turning of the body part. And sometimes they can be rhythmic, sometimes they can be tremulous forms also. From the videos that I saw in CACNA1A, I did not see much of oscillatory dystonic movements, although in couple of cases I saw some tremor, but I don't think it was related to dystonia, obviously. But dystonia in general is abnormal twisting and turning of any body part. It can be neck, it can be arm, it can be trunk, or it can be legs, anywhere. So dystonia is disorder of motor planning. So ataxia we thought of as disorder of motor learning, right? So one thing is you learn the movement and you plan the movement. So when everything I plan, right? I look at cup of coffee. That's delicious. Let me go get it. So my eyes look at the coffee. My brain processes it that, oh, I had this thing before. That was good. Let me go and grab it again. So then my eyes look at it again. Then I figure out what kind of movements I need to do to get to that and get to it, right? So one simple task like grabbing a cup of coffee requires lots of different processing in the brain. And all that processing needs to happen in specific synchrony. And when you lose that synchrony, that causes dystonia. Cerebellum is a master of synchronizing multiple things in domains of time, in domains of integrating one signal to the other, and whatnot. So if cerebellum has a lot of noise coming out of it, it can disrupt that synchrony, and then it is going to create problems such as dystonia. So here I tried to put together a little cartoon again, looking at the asynchrony, or what happens if you give unnecessary information to the cerebellum, right? So let's say if cerebellum is getting unnecessary, unwanted discharge, which happens in certain cerebellar disorders, including CACNA1A, possibly it can happen too. What happens because of this unnecessary discharge, cerebellum is just constantly sending barrage of unnecessary activity, right? When that happens, when you give an error signal to cerebellum, it cannot really trigger any learning. And when that happens, because it is preoccupied with totally something else, which is not necessary, it does not learn and you get ataxia, right? So that's one way of thinking of ataxias in this condition. But the same problem of this barrage of unnecessary activity, that leads to unwanted discharge. That discharge then disrupts the motor planning, because in order to plan the activity the discharges that come out of cerebellum and olive have to be precisely timed. And when that happens, that then leads to dystonia. And this proof of concept we have noticed in other olivocerebellar disorders where there is unnecessary olive and cerebellar discharge, and such as oculopalatal tremor, which is not seen in this condition, fortunately, but we do see that dystonia can happen. So the new theory of dystonia that we had proposed is that it is because of unnecessary random output that Purkinje cell gives, and that then leads to dystonia. My mentor and my colleague, Buzz Jinnah, he and many others had proposed a theory that when Purkinje cell is about to die or about to get destroyed, it gives unnecessary signal, which is not important for anything, just random firing. And then it causes dystonia. And when ultimately that Purkinje cell is dead, it leads to ataxia because there is no signal at all. So there is a continuum between dystonias and ataxias, and both can be seen together because of the same phenomenology. So again, dystonia versus paroxysmal upgaze, right? So this is another, so dystonia fluctuates from time to time, paroxysmal tonic upgaze fluctuates from time to time. But another thing about dystonia, it's a task or a context dependent, while paroxysmal tonic upgaze is not a task or context dependent. So that is the difference between the two. So this is one video of this cute girl. So what you see here is she's fine in this video, right? There is no dystonia. I don't see dystonia. I don't see any paroxysmal upgaze, mostly not. And as Dr. Grossman said, that there is second video of the same kid what you're seeing, there is paroxysmal tonic-up gaze, but to compensate for that, she's tilting the chin down. Now, is this dystonia? Probably not. This is the compensatory movement. But if you look at the hand, it has a little bit of contraction, right? So that is dystonia, because that is a task-specific. So if she's not doing anything, she's okay. But when she points out, it kind of goes up like that. So this is how one would separate dystonia from paroxysmal tonic-up gaze. I'll get some water. Thank you. Sorry. I spoke too loud. Thank you so much. So see what I mean? Like the hand is kind of doing this when she tries to point out to something. So the other interesting thing in other video that I saw is hand and neck dystonia with some intermittent tremor of the hand. So in this video, it is very short, but what you can see is, it is playing. But she has this, she tends to keep her head on her right side and chin down. So this is very obvious dystonia. I don't think that this is paroxysmal tonic-up gaze because there is a lateralization, right? So she's always trying to tend to keep the head on one side. And if you see, her hands are always contracted in a particular position. So this is dystonia more than anything else. Oh. And the second video of the same kid, you can see it when she tries to read something. There are like little oscillations every now and then, but they're very transient. If you look at the thumb on the left side, there was some oscillation. I rarely saw tremor, only in one other video I saw, but it was very transient, and it was for a few seconds and it was gone. But most obvious thing in this patient is the neck turning on the right side, what we call laterocollis. So this is laterocollis. Front chin up is antrocollis. Head back is retrocollis, and twisting like is torticollis. So in this child, there is prominent laterocollis and torticollis. So this is neck dystonia with some hand dystonia also. Her hands are like, her fingers are like this, so which is hand dystonia. Leg dystonia, which is something I saw very commonly in CACNA1A. So I have 3 videos to show you. So this person, as she walks, as you can see, her right leg tends to go out. And this is most common thing that I saw, that leg was twisting out when they try to walk. And this is, of course, probably an adult who is walking. And this other child who is trying to walk, as you can see, her right leg again is trying to go out, and as you can see, the hand was also a bit contracted on the right side. So this is another example of leg dystonia and hand dystonia as she's trying to walk. And very cute little kid, and he's not even starting to walk, but as you can see, the right leg is getting dystonic as he's trying to crawl, right? You see that? Focus, where's my arrow? Here. Focus on that leg, on the right leg. It tends to go out and it tends to stay contracted. So I think that is also dystonic in his case. So what can we do to treat dystonia? So there are medications one could use. Again, these were all the treatments for adults, but it can be used for little child. Benzodiazepines are something which we commonly give to treat dystonias with not a lot of success. Sometimes it makes it better, but not all the times. Baclofen is also had been tried in past, again with very limited success for treating dystonia. Tizanidine, again, it's a muscle relaxant, just like baclofen. Again, the response is kind of questionable. In some cases, it makes it better. Trihexyphenidyl is something that we typically use in adults, and it is successful in treating forms of dystonias which are because of medications, but inherited or cerebellar forms of dystonias, there is limited success. Amantadine, again, the same story. So medications, orally taken medications are there, have been tried. We're successful on some very limited cases, to limited extent. Something that works the most is botulinum toxin injection. But again, the problem with botulinum toxin injection is that it can help with dystonia which are focal, affecting small part of the body. If the whole leg is dystonic, it's a lot of toxin to give, and typically it creates a problem rather than treating dystonia. So something that my mentor had an idea, and he put together this Malin DeLong, that was deep brain stimulation, which works very well. Now I have to figure out this audio situation because I didn't hear. But what is deep brain stimulation? It's pretty cool. So deep brain stimulation is a way to do functional electrical stimulation. So what is functional electrical stimulation? So it is artificial way of stimulating the brain. So the way brain moves is it sends bunch of impulses from the neurons to different body parts. So what functional electrical stimulation does is basically it stimulates the brain and it modulates the output that goes to different body parts. Now, what you can do with DBS is it's like a tap. You can increase the stimulation, you can decrease the stimulation, you can make stimulation intermittent or stop it, right? And what happens in disorders like gait or dystonia or Parkinson or tremor, if you implant the deep brain stimulator, there is a computer in the chest, and you can actually program the computer to modulate the brain output, and by modulating the brain output, you can change the way brain is firing, and that then treats different movement disorders. We have real good success in treating Parkinson's disease, essential tremor, and dystonias using deep brain stimulation. But again, the question is, when do you use it? So I will show you one video, which is a success story for DBS. So this is not CACNA patient. This is a dystonia patient because of idiopathic, what we call retrocollis. Look at her neck. She is twisted back, right? And she also has this little head tremor whenever she tries to move forward, right? She has to assist what we call sensory trick, and it is quite robust. And she has very limitation of the movements of her neck. When she tries to twist her head in one direction or the other, it is very difficult, as you can see. Her head keeps going back, which significantly affects their quality of life, and especially in such cases, botulinum toxin was also not very helpful. So she got deep brain stimulation, and after deep brain stimulation, when stimulation was turned on, as you can see, her head is much more steady. She has very little difficulty in tilting her head. She can move her head very smoothly and easily. And that back turning was also good, right? So it works. The question is when it is right time. So the right time is when you are ready. So when people come to us for treatment of dystonias, especially the deep brain stimulation, which is invasive procedure, which is a brain implant, right? What we tell them is, we are ready when you are ready. So it all comes down to the quality of life, how much it is affecting the quality of life, what are the risk versus benefit. And everybody is a different case. And it happens very frequently in patients who have tremor, for example. Like I had some person who was a dentist, had a very fine tremor, we treated him with DBS. And there was another grandpa who was mostly retired, doing nothing, staying at home, and very robust tremor. It did not really affect his quality of life. We leave it alone. Because all these surgeries, they have their own problems. So the question is, when you treat it, and we tell our patients, we are ready when you are ready. So again, all the treatments, we are ready when you are ready.
Am I on? Thanks to the CACNA1A Foundation for inviting us. I'm so honored to actually join the panel with Dr. Grossman and Dr. Sheikh. So my slides are on. Okay, so you are all here because your child had one or more of the manifestations that are on this slide. And you're also here because somehow, after all the, seeing all the different specialists, and we're all super specialized, so you see a specialist for eye movement abnormality, you see another one for migraine, you see another for seizures, and you possibly see another for movement disorders, and somehow we all came together, and one of us recommended genetic testing, and that, and you're here because you actually have a diagnosis of a pathogenic or likely pathogenic variant for CACNA1A-related disorders. So the reason why I'm showing this slide again, I showed it last year, and is that we as specialists, we see different parts of the syndrome. And so it takes a lot of collaboration and for us to recognize that, oh, it's just different manifestations of the same beast. And so next slide, please. So this is a summary of the expression, what we do know about this particular gene expression. And this channel is actually very widely expressed in the brain. But if you look at this summary, you can see that it is especially abundantly expressed in the cerebellum. So you can see the yellow bar that, and the cerebellum is, I don't know how to use this pointer.
The green thing at the top. Well, that advances it.
Oh, so you can see the cerebellum in the back of the brain. That's the darker pink region. And so that is the theme for this particular panel. You would say, what's the connection for eye movement, dystonia, and imbalance? And as Dr. Sheikh also emphasized, that it's basically all the same thing. Abnormal function of the cerebellum that actually clinically manifest with dysregulated eye movement control and motor control and the control of truncal and appendicular movement. So this is just another diagram taken from a popular textbook on neurobiology showing the importance of the cerebellum, how the cerebellum actually integrates information from sensory input, from our visual system, and to actually smooth our motor execution, to do whatever we would like to accomplish. So this is a graphic summary for all the wonderful things that a baby would accomplish within the first year of life. So to allow this program to unfold, the brain actually would go through dramatic changes. So in fact, even during the third trimester, the cerebellum grows enormously. So there's really dramatic growth and development of the cerebellum. And this is also the time when you can actually feel the fetus move. And so it's not unusual for mothers, in retrospect, to share that actually the child had less movement than compared to other pregnancies, and so you can see from the pictures on top that somehow the baby is supposed to be able to hold the head up, and the baby should turn within a few months. The baby should be able to bear weight in the legs, and there comes a time when the baby should be able to sit up without support, and with some assistance can pull up to stand up, and over time could actually hold on to furniture to walk along. But around 1 year, the baby should be able to walk and stand without assistance. So that's the normal program. So somewhere along the line, your child may have had difficulty or was a little delayed, that actually prompted you to seek medical attention. So I would need help from the audio support to play these embedded videos. So when I played with it, I could just press. Okay. So we saw these videos before. So these are really, again, I cannot say enough to our appreciation for the parents who sent in videos. So the first one that Dr. Sheikh already showed, there's definitely overlap, that there's ataxia and there's also dystonia, in the sense that you can see the legs, the crawling, the legs were widely separated, and there was some difficulty in moving the arms in a very smooth way. And in terms of the baby on the left, in the seated position, in addition to the head bobbing, the whole trunk was unstable. And so all the movement is probably the brain attempting to correct the errors and trying to maintain stability. And so now we see, again, all the videos are adorable. We see this in the ballet class, learning to move the body, move the legs. But you can see that with every movement that disturbs a stable posture, that it takes a lot of correction to, again, reestablish stability. And there were times when she would have to take a few steps back to catch her balance. And that is also, again, truncal stability that is a manifestation of abnormal cerebellar execution. So, and here, fantastic, working with a physical therapist and trying to just stand still, and it's very difficult. So there's some to and fro movement. Again, it's the body trying to maintain stability. So the cerebellum goes through massive development during the third trimester and very much into the first few years of life. So in addition to a lot of neurons finding their way and making the correct connections, there are also synapses that are being trimmed so that we can make sure that information is transmitted in a very efficient and accurate fashion. So we're going to look at the video in the center. Rather than being able to stay on the carpet, you can see a lot of weaving, and this is also a manifestation of some ataxia. And also you can see the movement is slightly, it's not perfectly smooth. The gait is, the stance is broadened. And then this is probably a combination of, Dr. Shea can jump in, some dystonic movement of the legs, but also very broad stance in terms of the gait. So here is an example of appendicular incoordination, where it's hard to draw and maneuver the pen, and that is also in the realm of the cerebellar control. And you can see that when she looked up, that there was a little titubation, a lot of corrections to maintain stability. So here, so there's a reason why they're called toddlers. It's okay, wobbly, but you can see here that it's very difficult to maintain her stability, and that she really needs to lean on for support. And so here, this is also, again, very easy to lose balance and would constantly have to hang on. So these are all features of cerebellar ataxia. So you've seen examples of appendicular incoordination, truncal instability, gait instability. And so we take this combined with dystonia, with abnormal eye movement. For neurologists, they all localize to the cerebellum. And so none of these findings would be diagnostic of CACNA1A mutation. So this is why it takes time for your physician. I'm not making excuses, but I wish that there are more features, clinical features that are pathognomonic, that when you see this, it's got to be that or whatever, but there isn't such a thing. And so here we basically see a constellation of symptoms that would tell us that something is abnormal regarding the cerebellum. So something that we didn't have time to go into would be neuroimaging studies. I'm sure all of your children have gotten brain scans as part of their evaluation, medical evaluation. Again, it's very difficult to diagnose in the sense that the cerebellum is, again, the cerebellar development is a dynamic process. So, and we don't have data for, all different stages. And so early on, there could be, very subtle imaging changes, and it takes time for all of us to be sure about what it is that we're seeing, whether there's, decreased volume or continued degeneration. These are all questions that we don't have clear answers for every single case. And that's also why it is so important that we have all of you here and we can learn from all of you. So one thing that we didn't get into is that there's also limited penetrance in terms of genetic mutations, that it is not unusual, and we've seen many examples of this, that is, a parent would be found to be a carrier of the same supposedly pathological or pathogenic variant that a child was just recently diagnosed with. And yet the parent can be completely asymptomatic. And so there are modifying factors, genetic modifiers that we know for sure exist that can actually contribute to the clinical manifestations of this specific genetic change, so that the child was much more symptomatic than the parent, and with whom he or she shares the same variant. So again, there's a lot to learn. So there are treatment strategies that are available that we should take advantage of. And so I cannot overemphasize the importance of physical therapy, occupational therapy, speech therapy for speech and swallowing. Again, feeding difficulty is not an unusual early presenting symptoms. And also educational accommodation in school, that these are all things that we can already help support a child's development. And in terms of medications, those with seizures are already treated with anti-epileptic medications, and we have a separate section on management of hemiplegic migraine, but many patients don't have hemiplegic migraine per se, but they have complicated migraine as a manifestation, and that also requires special management. And acetazolamide, 4-aminopyridine, these are the standard treatment options for episodic ataxia and for downbeat nystagmus. And I do have a few cases, a few patients whose migraine actually improved along with the episodic ataxia in response to either acetazolamide or 4-aminopyridine. So again, these, as long as symptoms are different manifestations of the same thing, it seems reasonable that maybe we could come up with medications or interventions that can actually treat multiple manifestations. So I will end there and open up to questions for the whole panel, and thank you for your attention.
All right, I think we're going to start with a virtual question and then sort of go back and forth like we did earlier.
So the first question is, can nystagmus be episodic? And can it account for vertigo or other things happening during an episodic ataxia 2 period?
Sure. So I would say the answer to that question overall is yes, it can be episodic. The sense of vertigo, right, when patients describe feeling dizzy is actually a very, in some ways, nonspecific complaint, and it can be reflective of problems in a lot of different places neuroanatomically. But when our eyes are moving, when we have nystagmus, as you can imagine, that's not a time in which our experience of the visual world is static. So we may experience the world moving. For example, you may have heard of people having things like conventional BPPV or vertigo of the inner ear, where the eyes do a dance as reflected of a crystal moving in the inner ear, and they will feel experience of vertigo. So I would say, when the eyes are moving, that can be associated with the vertigo sensation.
So for episodic ataxia, patients who have actually made videos of eye movement during the attack, which is rare, it's very difficult to catch them. I've never seen a patient during an attack, but I've seen videos. And so usually there's more dramatic nystagmus. So the whole sense of vertigo is driven by the abnormal eye, the involuntary eye movement. So when the whole world is moving, it's very difficult to actually be oriented. And so indeed, that is a very common complaint. And that is also all the different types of episodic ataxia syndromes, it's probably episodic ataxia type 2 related to CACNA1A mutations, where patients actually report episodes of prolonged vertigo. And it's all related to the ataxia, the abnormal eye movement.
Hi. Oh, that's loud. My question for you all, since it's all kind of related, is are these abnormal movements something that with these therapies and treatments can improve over time, or is their baseline sort of set? Specifically with PTU, is it affecting their vision, their ability to see, and those types of things?
Sure.
So with regard to PTU, to the last part of your question, my understanding of it is that tends to be less of a feature as individuals get older. And so, PTU would not be something that I would say would prompt a need to see an ophthalmologist or someone to focus on vision independently of the diagnostic side of things. Sometimes people may be familiar with a condition where an eye can drift out, like in strabismus or something like that, and we patch the eye that's stronger to help the weaker eye get associated and help the brain develop in a way that can help us see better as we get older. But that's something that would be occurring all the time, whereas PTU is paroxysmal, meaning not all the time. And so if it's only occurring during a smaller amount of the day, then I would say that that's less important than in something like strabismus.
To answer the question, my understanding, the other question was all the abnormal movements that we talked about, gait and limb movements and whatnot, which affects your coordination and the therapy and the duration of therapy. Now, the way physical therapy works is basically it's reteaching the brain to compensate for the problem. And the teacher or the executor of teaching is cerebellum. What we have, and of course cerebellum is here not normal. What we have seen in our experimental studies, in our labs and in other labs, is that it is possible to teach the cerebellum that is not normal, maybe a dystonia or ataxia, but the learning is slow. So what we always tell our patients who have cerebellar disorders is not to give up. Your effect, your response to rehab will be prolonged. It will take more time than somebody who had just a stroke and cerebellum is normal compared to those people. The people who have cerebellar problem will take longer time, but keep it up and do your best. The other modalities that work well in some other conditions, of course, I don't have experience with that with CACNA1A, but I do have tremendous experience with Parkinson and dystonias. From other etiologies is music and dance therapy work very well. So when I was seeing the little girl doing ballet, I think that may have some rehab value to this, because brain not just learns from the information that goes from the limbs, but it also learns from information from the vision, auditory system, music. There are a lot of different nodes that brain utilizes for learning.
So I want to emphasize the fact that there's a lot of potential for the brain to, even the cerebellum, to grow and develop. And so, especially in the early years of a child's development, so I would echo what Dr. Sheikh said, that you have to persevere. And I think that physical therapy is tremendous, and it can be a tremendous resource, because moving is definitely better than not moving. And so definitely support the child to play, to go outside, and to participate in activities that is fun for the child.
And
Thank you. Oh,
two of my mentors had taught me two different things. So David Z's favorite thing was ping pong. Play ping pong, very good for balance, and John Lee loved tango. So do tango for balance.
Do both.
Do both.
All right, thank you, panel. I saw a hand up front, and then I'm going to hand it over to Amy for a virtual question, and then I'll run back out.
So, in my case, when I have a full onset, I get like it'll like twitch around my eye, and I'll get blurred vision and double vision that comes on. My attacks, I'll get the slurred speech, difficulty swallowing. I say I look like a drunken sailor. My attacks can come on and last for just really quick, or they can last for days. And they just began in the last couple of years, and they're progressively getting worse. My children all have the same gene mutation. But the eye thing is something that, how do you go to an eye doctor and say, hey, this thing comes on, and like you'll see I have to wear readers, but it's one of those things, like, you get the double vision, you get the blurred vision, and then your vision is fine. So it's like there's no, like, how do I compensate for that when, kind of like the other things, you go in and it's like, well, it's really been awful all week, but when I got here, now it's perfectly fine. Like, I don't, a way to compensate for that when it's going on, I guess.
Yeah, of course. So thanks so much. That's it's a complicated question, and you're describing a number of different things that could be affected. Some things that come to mind are when you're describing the skin around your eye twitching, called blepharospasm. Sometimes that can be amenable to things like just a Botox injection to the skin or the muscles around the eye that can make that less distracting. And oftentimes folks have a sense that their eye is moving, but in fact what it is that the skin around their eye is moving, and that's leading to a change in their vision. With regard to double vision, it depends a little bit on the kind of double vision that you have. if it's the kind when you close one eye and you see single, then those are the kinds of things that are amenable either in the short term when you have an event to patching one eye just briefly, or there are even kinds of glasses that can incorporate prisms that can account for the degree that your eyes are misaligned, leading to the double, that could help you during the event. In some, one of the things that your question is bringing up is the difference between ophthalmology as a field and neuro-ophthalmology as a field, because ophthalmologists are focusing primarily on the eye itself, but you have a vision problem that's related to the way the eyes are coordinated with the brain. So one of the things that I would suggest, if possible, I'm not sure where you live, but would be to establish care with someone in neuro-ophthalmology who'd be able to serve as a resource and coordinate care with your ophthalmologist, a primary eye doctor.
But what you're describing actually sound like episodes, right? Spells. And so I think that it would be very difficult to actually try to treat a moving target, right? It would be impossible for any neuro-ophthalmologist to basically figure out, exactly, specifically what kind of prism to fit for your, during your attacks. And so, in fact, the priority of treatment should probably be controlling the spells, rather than, specific individual symptom, during the spell. And so that's certainly something that, it really depends on your doctor, and we're all happy to collaborate and work with your doctor in managing your symptoms, okay?
We have a special guest who would like to come up to the stage
Please.
and have you watch her walk.
So this is Gabby. Hearing what you say, I think she has a couple maybe different things. She's the ataxic walk, but maybe some dystonia too. I think as a parent, it's hard to have all the right words and to know. So anyway, so she's 8. She was diagnosed 7 years ago, and we've done a lot of PT and OT with her, but still she has a lot of imbalance.
Of course, yeah.
Okay. Gabby. Upstairs. You can show off this walk, yes? I think she also has, hypotonia. So that.
There you go. I can grab her.
So she also has, hypotonia. So I think that relates as well to some of her difficulties. But let's see. Do you want to walk?
Should I let go? Sure.
Right, let's see. She can walk independent, but only about 8 steps, because then she'll just start to feel like really off balance, I think, and so she doesn't feel comfortable. So she usually wants to hold a hand. And then pretty wide-based gait is my understanding, but I don't know what you want to comment on her gait, because to me it's maybe a classic CACNA1A gait, or maybe not. I don't know.
I mean, there is dystonia, there is ataxia, both. And what you said about hypotonia, it can be cerebellar, or tone can also spontaneously fluctuate with dystonia also. So it can be multifactorial, I think.
So overall, ataxia and dystonia.
Ataxia.
Here you go, Gabby. Can you do any independent? There you go. I know, it's hard.
Good job.
And so she always feels
Unsteady.
unsteady, but she's quite aware of her unsteadiness, so she doesn't fall a lot. Like she usually stops herself and steadies herself.
Thank you for coming up.
Okay, bye-bye. I don't really have any specific questions, I don't think, other than we just kind of try to do a lot of PT and OT to increase her tone.
You're doing absolutely the right thing, and
All right, thank you for that. We're going to jump to a virtual question really quick, and then I think I saw a hand in the back earlier, so okay.
Thank you. One of our online participants is asking, what are the implications of PTU and what should be communicated to educators and caretakers? In their particular case, their son is nonverbal.
Well, right, yeah. I would say that, it's one thing that about PTU that's notable is that that's the same, right? So it's a characteristic spell or characteristic episode. So hopefully if a child is in a class or in an educational setting, you can communicate with the teacher in a way that they may be able to reliably identify the episode itself. One thing that comes to mind is some of the patients that we had a chance to see videos of also where when they went to sleep, the episodes improved. So, I wonder about coordinating time for during a school day or during a preschool day with nap in terms of PTU. And I would say that it may be amenable to just typing up a sheet of paper that says, my child has this condition, they have this change in their eye movement that you can expect to see sometimes. One thing that I had talked to Lisa about a little bit in preparation for today was sometimes folks have a hard time differentiating episodes that could be seizure versus episodes that could not be seizure. So it's important to characterize episodes that come and are paroxysmal with the input of video EEG to see is there electrical brainwave activity that could indicate this is a seizure. If it's not, and it's unlikely to have a vertical gaze deviation to be a seizure, then you can also offer some counseling and reassurance to teachers that it's unlikely that they would need, for example, a rescue medication to help stop a seizure that's come on.
So it's not unusual for patients to present with PTU early on and then would later begin to develop migraine and episodic ataxia. And so one way to think about these conditions would be that there's a threshold and that sleep deprivation, overexertion, dehydration, or not eating on time, that these are very common triggers for the symptoms. And so it's a matter of, for the parents to actually keep track of these symptoms and see if there's a way to regulate and maintain a very healthy lifestyle for the child to minimize. So if sleep relieves the symptoms, then maybe she should get plenty of sleep, so to preemptively, right, prevent episodes. And so these are just things that, again, until we find gene-specific treatment, we can just work with the body to, to prevent symptoms.
All right, thank you. So for the sake of time, I have a question here, and then I'm going to go right up front, and then I think we might be done with the virtual questions. But again, please remember we are having a break after this, so you can just continue your discussions afterwards.
Hi, I'm just wondering, is ataxia likely to get worse if there's, progressively worse, if there's volume loss in the cerebellum, if there's any data on that? And then separately, I noticed with my daughter, she's 3.5, that her ataxia gets worse and she's got an intention tremor when she's sort of sick or really stressed. And I'm just wondering if we know why that could be.
So I was trying to understand your question. I couldn't hear well because of my mask, but the question was ataxia progressing to intention tremor?
Is ataxia progressive?
Is it progressive? And also, is there any correlation between the ataxia getting worse and cerebellum loss?
Oh, okay. Yeah, I mean, ataxia in cerebellar condition can be progressive. It is possible. And cerebellar Purkinje cell loss do correlate with ataxia severity as well. And intention tremor, you asked about that also? And intention tremor intention tremor can be from cerebellum or it can be dystonic. Like if you try to read something, it can have a dystonic feature. It can be dystonic tremor also, or it can be outflow cerebellar tremor also.
So I think the question of whether or not ataxia can be progressive, we may have to, this is why you're all invited to participate in Dr. Chung's natural history study, because I don't think that we can generalize for that all mutations are not progressive or all mutations are progressive. As you can see, some manifestations are more severe than others. And so I think that we need to look at this on a case-by-case basis. And so if it's any reassurance, another disorder that's related to CACNA1A is spinocerebellar ataxia type 6. So it's not exactly a channelopathy, but it is related to the same gene. And so of all the spinocerebellar ataxia syndromes, this is probably the one that's associated with the slowest progression, if any. So basically, in 2-3 years, it's very difficult to even detect an obvious clinical decline, if it's any reassurance. But I think that I understand where that question is coming from, and I know that you just want information, but it's probably information that we don't yet have, especially if we don't know if I don't have the information on the specific nature of the mutation. But the most important thing is that, again, we hope that everybody participates in the natural history study so that we can at least see, have some baseline so that we can see, in 1 year's time, in 2 years' time, is there a trend? How are things going? And so the complication in evaluating a child is that the cerebellum continues to develop at age 3, right? So there is room for growth and development. And so I understand that reaching the motor milestones was a little delayed, but it doesn't mean that she won't get there, okay? So we just, again, we need information, and so sorry about that long-winded answer.
I have a two-part question. The first is that when my child was first diagnosed, her eye movement disorders were the first thing that we noticed, and that was our first stop. We went through a range of diagnoses from an oculomotor standpoint. The first one, and one that seems to be recurrent, is oculomotor apraxia. Could you describe where on the continuum that sits, or if could that be a feature in addition to the CACNA disorder that she has? And then the second question I had was, we talk a lot about physical therapy for the ataxia. I know there are some oculomotor therapies. Is there any data showing benefit to that for our children?
So oculomotor apraxia, it is reported in cerebellar condition, but I have not seen any in the videos or patients that I've seen with CACNA1A. So ataxia oculomotor apraxia, AOA, is another condition, and that can be seen in cerebellar. Cerebellar involvement is seen in that condition, but it is different. It's very different from this. The other causes of oculomotor apraxia is cortical. Again, that has it's very different disease compared to CACNA1A. What I have seen in CACNA from the videos that you sent and the literature and all is generally it is paroxysmal, and it is not oculomotor apraxia. Now, if gaze is tonically up and you're trying to ask them to move from one direction to the other, so that tonicity of the motor tone, which drags the eye in one direction, that can interfere with the latency, and then it may look as if this was apraxia, but phenomenologically they are two different things.
So this is why I think that it's so important, and it's very, very valuable for parents to actually make video recordings. And so we can all, I think that there are different labels that we can put on different things, but I actually learned a lot from going over the videos that Dr. Grossman and Dr. Sheikh presented, because they saw features that I didn't see. And so I think that we could definitely use more input on, from experts from different areas to actually thoroughly evaluate the clinical manifestations so that we can actually have a better understanding of the clinical features in different patients.
What was your second question? Sorry.
Just whether there was a role for oculomotor
rehab. Yeah. I mean, in my oculomotor practice, I have not seen that big of a success with the vision therapy, what they call. This is my honest opinion, but there are other people around there who believe in vision therapy. I don't know what you guys think about
Exactly, yeah. And this is a controversial area in terms of understanding whether or not folks are amenable to this kind of intervention. My experience has also been no. Though we do know within NYU we have the Rusk Institute, which is our rehab center, and we work with both PT and OT there. And the time in which I send folks to occupational therapy from a visual standpoint is really more in difficulty with moving the eyes together, convergence problems. And that's been shown to be amenable in the literature, but not oculomotor therapy for the kinds of things that we've talked about so far with CACNA1A.
Now, one thing that is super effective with physical therapy or rehab in the realms of oculomotor is vestibulo-ocular reflex, but that's not an issue in CACNA1A anyways, like vestibulo-ocular reflex hypofunction. So when we say that it does not, in our experience, it did not work, but that does not apply to VOR. For other things, what we meant.
Yeah. And to clarify, just the VOR is when we turn our head and our eyes have to keep focused on a certain object that we're looking at.
But I think the most important thing that you mentioned was the fact that the very first abnormality that you noticed was eye movement. So indeed, eye movement is a window to the brain, as Dr. Sheikh always says. And so maybe that would actually alert the clinicians to reach a diagnosis sooner. And so again, I think that the problem with eye movement abnormality is that the circuitry is set pretty early in life. And so even in other ataxia syndromes, eye movement is not even part of the tools to assess progression because it doesn't change. And so the hope that we have is that right now, we're using it to help us reach a diagnosis. But it is our hope that as we develop gene-specific therapy, that maybe we can intervene early so that there's actually room for remedy. But right now, there's going to be some impairment just because of the instability of gaze, that there is some decline in the visual acuity, but the child is not bothered by blurred vision because this is how the child developed. And so the person is not dizzy per se. And but it is an area that I understand is very frustrating.
If I could just piggyback one more thing, which would be one thing that is my takeaway from this conference is that there's a role for the CACNA1A community to be able to be educational for folks like the neuro-ophthalmology community at annual meetings, like our Nano Society, where it would be a way to reach individuals who are seeing first-line people who come in with problems with eye movements in childhood or in adulthood. And there are certain ways that I can think of that would be helpful for education of the physician community in this way.
And the other important implication of eye movements and its early diagnosis and early treatment is learning disability. I mean, eye movements are so important for capturing everything. And if you are not capturing things correctly, then that has a downstream consequences in learning. So it is also very important.
All right, thank you, panel. We're going to jump to another virtual question right now.
So this question is about dystonia. Is the right side, is it more prevalent on the right side than the left? And if so, what is the difference of these projections from the IO to the cerebellum when it goes to the right or the left? Does it hint at what mechanism?
Well, I mean, it's basically dystonia is imbalance in the muscle tone. And if it is right side, I mean, one side is always going to, I mean, it's not symmetric always, right? So unless it is affecting the axial muscles, which is controlled by both sides of the brain, then it's going to be on one axis. But when you are affecting the limb, one limb is always going to have more involvement than the other. And most patients that we have seen in the videos, they did have involvement of both sides. It was just one side was more robust compared to the other. So there is lateralization, and lateralization, what that all means is brain is not able to compensate one side as well as it does the other side, but that does not mean that other side is normal. Sometimes we do see what we call hemidystonias, but the hemidystonias are typically not, I have not seen that in CACNA1A patients. I see that quite frequently in patients who have stroke, but that's a very different etiology, it's very different mechanism also.
Okay, and I will go with one last question from the virtual side. Somebody wants to know why is there pronounced dystonia during a hemiplegic migraine?
Why they get dystonia during hemiplegic migraine?
Yeah, more pronounced, yes.
Well, I mean, I will answer some, and then we can both together do that. So my take on this is twofold, right? So it's an episodic phenomenology. Dystonia, migraine, ataxia, eye movements, they're all episodic phenomenology. And the way we described it is a network. It's kind of everything together, right? So if system goes haywire and it's going to create a problem, at a given epoch, it's going to create all the constellation of symptoms, right? So it is possible that with hemiplegic migraine, dystonia is also worse. Now, let's say if somebody has baseline dystonia, any movement disorder get worse when you are in any kind of physical stress. So let alone CACNA, if anybody has like regular idiopathic cervical dystonia, it is going to be worse when they get a regular headache or even flu to that extent. So any kind of physical distress can make any movement disorder worse. So there are two explanations and they are mutually inclusive.
I don't have anything to add.
All righty, and so with that, oh, sorry, so if you have any more questions, you can continue them. No, you want one more?
We can come up after. Yeah.
Okay.
Just to let you know, if anyone needs to take a break, there's refreshments outside, but we're going to keep asking questions.
Okay.
Sure.
Okay, all right, there was somebody over here, and then I'll run over to the other side.
I have a question about like the chronic ataxia versus my daughter was diagnosed with the downbeat nystagmus, and so not during episodes. She has episodic ataxia. When she has visual spatial issues and like doesn't seem to just look down to see that obstacle in front of her, whether it's a rock, and just trips. Is that a visual or is that the ataxia?
Do you mean during the episode or
No,
in general?
chronic, just.
And what type of nystagmus she has?
Downbeat.
Downbeat, okay. So she has a chronic tendency of upward tone, right? So her eyes have chronic tendency of going up, and that's how the downbeat nystagmus works. So there is a mismatch, and the eyes drift up, and it beats down, right? So possibly at baseline, she had difficult time. Its eyes are always chronically going up, so that's one thing. And the second thing is, of course, downbeat nystagmus by nature, it's an issue with in the pitch axis, right? So in eye movement, we think about aerospace, right? Pitch, roll, yaw, all that, right? So it's a pitch axis, this axis, right? So she tends to kind of fall in along this plane. So those are the two explanations I can give.
So what we usually tell patients, actually even those with downbeat nystagmus, one of the simplest things that we can help them with is, for example, don't get bifocals, right? And that sounds trivial, but it makes a huge difference because your daughter may not be old enough to need bifocals, but I'm just throwing that out as an example, that they have special trouble looking down. So if you even have a different lens for looking down, then we're just compounding the problem. Okay, and so downbeat would actually be accentuated because there's already a drift upward. That's driving the downbeat nystagmus. And so on looking down, it is even more, the downbeat, the amplitude is usually even more accentuated. And so looking down is difficult. And so I think that this is why, going up and down stairs can be very dangerous and hazardous for these patients. And we always have to caution them. And that just being in an accessible environment without steps, or just being cautioned that they would have trouble. I mean, even stepping off of the curbside can be very, very difficult. So again, understanding the problem and telling patients, for example, little things. There are patients who can't read. They're very frustrated But it's because if we read normally, we look down, and that is just impossible. So we just recommend get a book stand. So if you look at it from eye level, it's a lot less challenging. So again, I totally understand it's very difficult. There's no simple solution. But one medication that we can try if she hasn't tried it is formiminopiridine.
Yeah, no, that's been a game changer for her.
Okay, great.
Okay, and I was told we have time for one more question, and then our wonderful AV team actually needs a break so they can set up for the
They
next
need a break.
set.
Good.
Yes, okay,
No,
so
thank
I'm
you
going to
for
go
your
to the
help.
front, and then we'll end it there.
Good morning, everyone. Before I get to my quick question, I just want to take a few seconds to acknowledge and appreciate all the good work that Foundation actually has been doing since its inception. And I know a lot of time and effort actually goes, behind the scenes. So thank you. Yes. And also, thank you for expert panels. Having specialists who just deal with specific challenges that us families kind of deal with on a day-to-day basis is just incredible. And not to discredit our providers back home, it's just having specialists from this specific field is just really good. So thanks again. Question is, you guys mentioned it's really important to sort of distinguish the non-voluntary movements, stemming from conditions that we just discussed, as opposed to, coming in from epilepsy, from other activities in the brain. So for us, in our specific case with our little one, we've gone through like MRIs, EEGs to find distinction between all the non-voluntary movements are seizures, is it epilepsy, or is it something else? But are there any additional type of like conclusive tests available that we can go back home and ask to sort of find out what is it that we're dealing with? And please excuse me, not able to sort of articulate my question in a more I guess medical sense, but still trying to understand what's going on. Thank you.
Yeah, I think one thing that you could bring up with the team of doctors that you follow with at home is the nature of the events themselves. So some things, what's called the semiology of the event, are more likely to be epileptic than non-epileptic, or other things like movement disorders or primary eye movement problems. I know we have an epilepsy session later on, so I think there'll be a lot more information that comes forward then. But for example, this PTU, right? We're taught in neurology residency that sometimes people who have seizures can have gaze deviation to the sides that stays there, which is different in nature in semiology than up gaze that stays there, right? So certain clues like that you can discuss with your neurology team will be able to help them clarify, what constitutes an epileptic seizure event versus just a paroxysm that's not epileptic.
So I totally understand the frustration, but one of the ideas that the foundation had considered was sort of have like ask the expert type option for patients to send in questions or whatever. But you can also imagine that it can be very time consuming for for the experts to respond. And again. I think that it's very, very helpful. I'm steering everybody to the natural history study because hopefully that's a place where all the information can be captured. And if you can take the time and write down basically whatever, you don't have to worry about the medical terms, right? If you just write down what you see that bothers you, that you don't have an answer for, then we can see what we can do. How's that? Just make a list, and we'll see what we can do, okay?
All right, we are going to end it there. Thank you so much to our panelists.